It's a pleasure to follow after that presentation by Joy, because we're talking about the same thing sort of differently, and we're going to reiterate the themes that we've talked about all day long, but we're going to give you the actual words of patients and their caregivers as they've gone through a NETs journey. We're doing a study on patient and caregiver perspectives on the difficulties diagnosing and treating is missing from there, carcinoid neuroendocrine tumors. I'm Deana Midmer, and this is my colleague Talar Bayajian, who is a medical student in the making. She is one of our future physicians who will know all about NETs and be able to teach about NETs and be able to hold seminars with her fellow students, I hope, about NETs. She is here with her partner, Armen, who is actually a medical student in 4th year at Western, and he is going to be presenting part of this project in Montreal. So we have 2 budding physicians in the room, which increases our number of budding physicians exponentially, I believe. I also wanted to thank Maureen, because Maureen is part of our group, as are Carol Bates. Carol, where are you? Carol's going to be presenting this in a conference next week in Calgary, which is called the Family Medicine Forum, where hundreds and thousands of family physicians attend. Lisa, where are you? Lisa Alter, who's part of the study. Diane, sitting over there, she's part of the study. And then, of course, Jim. We all got together and did this study, and we're presenting it here and in Montreal for the CNETs. But as I say, the Family Medicine Forum and another very important conference in Montreal called the North American Primary Care Research Group, which is a mouthful, but that's all family medicine researchers. So this study is getting 4 exposures, and then we're going to put it into print and hopefully get it into an academic journal by the end of the year. So let me just tell you what we did. Thank you.
Thank you.
And what do I do with this?
You advance
this
the
one?
slide.
Okay. Just as a matter of form, conflict of interest, this study was financed by a small grant from CNETs, and it was a non-restricting educational grant. Traveling funds were donated by the Lawson Foundation, which is in London, Ontario, and no pharmaceutical funding was used for this project. I'm going to skip a lot of these slides. These initial slides are meant for those other 2 audiences I mentioned, family physicians who really know nothing at all about carcinoids and neuroendocrine tumors. I'm going to slide through all of these because you've heard this today, but we will talk about what are NETs, what are neuroendocrine tumors, what are carcinoid tumors, how do they manifest, what's carcinoid syndrome, the prevalence of NETs, and again there are differing numbers, but there seems to be a common understanding that there's a growth in the number of people being diagnosed, maybe because of the aging population, maybe because of better diagnostics and scans. Treatment for NETs, you've had presentation after presentation on that. So here's the purpose of our study, to explore patient experiences with the diagnosis and treatment of their NET, to explore caregiver experiences caring for a loved one, and to identify potential areas for improvement in the comprehensive care for NET patients. We used 3 focus groups of people who have NETs, 2 of patients and 1 of caregivers. They were chosen from the membership of CNETs, and we obtained ethics reviews through the University of Toronto. We had a professional focus group facilitator provide services pro bono, and we interviewed people before they attended the group to make sure that they were comfortable discussing their problem, and we gave them a small amount of food and we paid for their mileage and parking. We used a specific guide so that each group got the same types of questions, and we had Talar and another experienced field observer behind a one-way mirror taking notes throughout the sessions and developing overall themes. The data is locked in the Department of Family and Community Medicine at the University of Toronto, and Talar is the only one who has access to it. We did that to protect confidentiality. We used a constant comparison strategy, and we had reviewers review the transcripts, and we came to clearness on main themes. Here's the demographics of our patient group, and I'm not going to spend any time on this at all, except to say you can see in the column the age at the signs and symptoms, age at their diagnosis, and years from signs and symptoms to diagnosis. And in some instances, it's only 2 years, whereas in other instances, it's 24, 25, 23 years before they were finally diagnosed, their present age, and then the wide range of types of tumors that they had. And that goes to show that it's not a disease, it's just a disease amongst many. Patients felt that there was misdiagnosis and difficulty coming to a diagnosis. Different physicians often seen in order to reach a diagnosis. Because they had small indolent tumors, they had vague symptoms, and when the disease was diagnosed, it was quite advanced. And they knew that they would have had a better prognosis if they had found out earlier.
So I'm just going to read some of the quotes that we found throughout the focus groups. So the biggest difference between CNETs and other cancers is the time to get diagnosed. If they had diagnosed it earlier, my symptoms would have been much less and I wouldn't be as sick. I had several doctors and had tests for over 10 years. Most people don't find out the tumors are there until they've grown and spread. You're at a point that it's too late.
However, one patient said,
I had a positive experience. From the time I was diagnosed and seen by a specialist wasn't long. Maybe it's because my doctor had seen it before and knew what steps to take me through.
Financial distress was something that patients experienced. They found it hard to keep a job while they were experiencing carcinoid symptoms. Considerable travel time was needed to get to treatment centers at a distance, and sick days were soon used up, meaning that they had to have unpaid time off work.
I had to stop working. I wasn't planning to retire, so it caused financial strain. People I've seen with colon cancer were off 6 months and go back, but I can't. I lost my job, had to pay for drugs, no disability money from the government, and no CPP. All in all, I lost everything.
Patients also felt a great deal of uncertainty. There was no reliable way to predict the disease progression in their prognosis. Because of this uncertainty, decisions about home ownership, vacations, actually any plans for the future were put on hold.
My doctor said 6 months or 10 years. You're left not knowing. You're not able to plan anything properly. I'm not getting pregnant until he gets stronger. If I get pregnant, I don't get paid if I don't work.
Patients determined that they had a poor quality of life, and this relates to the previous presentation. They found it difficult to make plans, and it was hard to keep promises to socialize with friends and families. The course was so long and chronic that they became more and more isolated.
This is draining. I'm tired all the time. This goes on and on and on. Not one surgery and you're over. Every day it gets worse and worse. There's no cure like for other cancers.
Yet another patient said,
it hasn't affected me until now. I've been lucky. It's comforting to know I have a certain amount of time. The last 8 years have been the best years of my life.
Patients feel lonely. Because of the different CNETs manifestations, there's a lack of commonality of signs and symptoms. Patients receive general support, but they didn't get specific support, which is what they wanted. And some experienced difficulty in discussing their diagnosis because of a sense of pride or because they knew that people wouldn't understand about the disease.
You work very hard to appear you don't have a disease. I don't want people to feel sorry for me. Other forms of cancer are well publicized, run for prostate, breast cancer, etc. But CNETs nobody knows. It's a shame it's not acknowledged. It's like you're not really a cancer patient. Oh, so you have this odd thing.
The role of support groups factor differently for different people as well. Some found the meetings depressing, some found them positive, some found that it was a place to go to talk about the disease and new treatments, and that's where a lot of people learned about physicians and places that they could go, both locally, regionally, nationally, and internationally to get help.
I don't go. I don't want to spend time thinking and learning if my tumor is going away for good. In some ways, I want to be better educated, but my life is bursting at the seams with a full-time job and a husband who travels.
Patients found huge comfort in faith.
I don't know how people deal with any of this if they're not grounded in faith. You just carry on by the deep, abounding faith that can do wonders.
Patients talked about the role of caregivers in their life, the person in their family who was actually there for them. They said they provided emotional, physical, and instrumental support, that they needed to be knowledgeable about the complexity of the disease. They acted as the patient's advocate and voice in the medical system, and they act as family system buffers, answering the difficult questions from family members.
Is mom going to be okay? Is mom going to be around? I would find it almost impossible to go without my caregiver. After an appointment, I ask my son what happened. I get so tense. I don't remember the finer things. I couldn't go alone. I don't feel that I'm sharp enough. As a caregiver, you have to turn yourself into a researcher. My role is understanding the language. The patient doesn't hear everything. We try to back it up. You want to know what's going on, and you ask questions they don't ask or forget to ask if she is in shock or doesn't want to aggravate the doctor.
Caregivers themselves experienced emotional turmoil. Caregivers felt that they were in for the long haul and that their own lives were changing dramatically. Many caregivers indicated that they were overtired, frustrated, angry, and that they needed support and respite.
I have to change her Depends. She's going through 10 to 15 bouts of diarrhea a day. I went to my family doctor after a bad meltdown. It was like my husband was my baby when he first came home after surgery. I'm a pretty tough cookie, but having to work and being a primary caregiver, I was so angry at this disease.
The healthcare system was, in many of the participants' eyes, lacking funding. Because of the rarity of the disease, there was just no money being poured into it.
You don't get funding, you don't get research, you don't get cured. You get annoyed with all these fundraisers. I feel sorry for all those people with breast cancer, but we're dying from cancer too. We feel neglected. We're an orphan disease.
Lack of technology and drugs was also important. The limited drugs available in Canada, forcing patients with financial resources to seek treatment abroad. Smaller tumors went undetected because of a lack of cutting-edge technology, and they had incomplete information on the disease and on what treatment would be appropriate.
When I had a CT scan, they saw 2 tumors in Canada, and in Sweden they saw 10 tumors.
They felt that there was a lack of algorithms and protocols, and you did see some algorithms today, but I don't know how widely disseminated they are. But this lack of information confuses care issues.
I have a wife who has had both breast cancer and a CNET. With breast cancer, there's a system, there's a process. You're diagnosed, you have an operation and subsequent chemo or radiation. CNETs are totally opposite. There's no path. There is no store with a sign that says CNETs identified or treated here.
Physician issues, they felt that there was a lack of awareness, a lack of knowledge and expertise, that the patients felt the need to go to Europe for care where they do have designated centers of excellence, and patients and caregivers both wondered why Europe was so far ahead in their understanding, care, and treatment of NETs.
Lots of doctors don't even know what carcinoid syndrome is. I know more about carcinoids than my doctor. He asks me questions. One doctor told me that carcinoid was not cancer, that it was not malignant, and that I shouldn't worry.
Physicians, they felt, were resistant to information and research from the patients themselves. Patients felt they had to advocate for themselves and were much more positive if their provider encouraged them to be involved in decision-making. Other patients found their physicians resistant to hear about new treatments or studies.
If you bring them information, they say they don't have time to read the material. They believe they know it all.
Yet another patient said,
"My doctor is teaching his students based on this case. He said if I find new material, would I deliver it to him? He wants his patients to be involved.
Physicians, they felt, could also be dismissive. There were differing opinions about this. Some found that their physicians were arrogant, that they felt dismissed as a patient and were told the symptoms were all in their head. Others found compassionate physicians who always listened to them and they felt valued.
There is a lack of listening skills. That's what I'm getting big time. You're looked down at, not as an equal. You look healthy, so I don't have to worry about you. That's the impression I get from my oncologist.
They also discussed territoriality, that receiving care abroad led to disinterest by Canadian doctors who did not want to get involved or give follow-up care. If patients were put on a medication regime while abroad, the Canadian physician would sometimes refuse to prescribe the medication even if it was available in Canada. However, some found their physicians were very receptive to alternative care ideas.
I've gone with a letter from specialist to specialist. They were not interested in looking at it. He said, I do my own testing and this is what you get. I was told to stop taking my meds and to try a trial. Why would I stop something that is working? I went to England 3 times. It was pre-approved by the Ministry of Health, referred by my doctor, and it was another positive experience.
They felt that there was a lack of patient education coming to them from their physicians. Physicians who do not know about NETs do not spend enough time educating patients. The onus is on the patient to find out about their disease and possible treatments. Patients without computer skills were at a disadvantage, and the energy drain on patients looking for information was considerable.
My wife will be online all night. If you're not that type of person, I feel sorry for you. You are on your own. Nobody cares. Someone says have chemo. Someone says it doesn't work for low-growth tumors. You don't know what to do. I talk to 3 different doctors and get 3 different answers.
The study limitations were that this was a small study. We only had 2 little focus groups, and if we had more groups, we probably would have had more themes or more input. But we did reach some saturation with our second group. These issues were all very important for all of them. The participants all lived in southern Ontario, so we're really only talking about care received perhaps in a very small part of Canada rather than a sort of pan-Canadian experience. So what do we need to do? It was our belief after finishing the study that NETs needs to go mainstream, that CNE is needed for all physicians, that care algorithms and protocols need to be disseminated and followed, and oncologists and surgeons working with rare cancers should be financially supported. There is the feeling that if you are dealing with a rare cancer, you do not get the same per capita income that you would get if you were dealing with something like breast cancer, where there's a very large patient load. And that might predispose physicians to not enter into that field. So we believe that there should be some parity and physicians would be paid commensurate to their peers who are dealing with a more common cancer. Educational resources are definitely needed for patients, and educational materials should be placed in family physician offices. Although we heard that many referrals came from oncologists, a lot of the times the vague symptoms are first discussed with the family physician. And Doc, I feel that I'm flushing. Oh, that's menopause. Doc, I feel I've got diarrhea. Oh, that's irritable bowel syndrome. So you go to your family doctor first, and that's why sometimes there's these huge delays in finally getting a diagnosis. So materials need to go into family physicians' offices, not oncologist offices. We believe that there should be patient navigators to help clarify the therapeutic strategy for each patient. Someone you could call and say, look, this is what I have. What are the options for me locally, provincially, nationally, and internationally, so that the patient was spared that burden. We felt that centers of excellence needed to be developed in Canada that accept referrals nationally. That silo cancer management at the provincial level is not appropriate for NETs. and that attendance for cutting-edge care outside of Canada should be funded for patients. They should not be penalized because they've gone abroad to get the care that they need. And I'd like to acknowledge, thanks to Tanya Hertzman of the Hertzman Research Group for the focus group facilitation. Thank you.